Final day Friday. It's a bit sad. Yeah, but we've got party tonight, so don't be too upset. We've also got an iPad to give away today, so if you haven't yet filled out the form from Delphine and Max, they do have a QR code up there. Fill it out. In the middle session after photo competition, that iPad will be given away. So certainly if you get to do that, put your name in the draw. You've probably got like a, 1 in 150 chance. So yeah, things are looking good. Big thanks to Rob for the great workshop yesterday afternoon. He's got another workshop on this afternoon. If anyone's still keen to do some PD in between conference sessions and closing party, we do have a couple more spaces. So yeah, if you don't have to do your final suit fitting or pick up your shoes, I've got my new Birks on today, I'm pretty excited about. That's certainly sorry, you need to... oh, that wasn't good. Yeah, there's certainly an option there. Otherwise, we're just going to roll on through 4 presentations this morning, break in the middle. As always, sing out if you need anything. First presenter is, I'd almost say he's a Hoi An local. Eb's been able to give us some great tips. For those who booked tours through Sun Tu, that was all thanks to Eb's great recommendations and organising. So extra big round of applause for Eb for presenting and also their recommendations. Thanks, Eb.
Thank you, Quentin. I might just stand here. I think it's a lot easier and you can see the screen. My name is Friedrich. Welcome to Vietnam, or as they say, Chow Im. So you're familiar with Sing Chow? So Chow Im is a phrase that when you greet somebody and they're younger than you. So I'm pretty confident in this room that I can use that phrase. Because if anybody's been in this business longer than I have, they need their head read. Coping with Vietnam okay? Yeah? How you going with the traffic? Anybody in hospital, Quentin? We lost anybody? They're all okay? Yeah? Okay. So yeah, we should have given you some tips about crossing the roads. A good method to use is called the Moses principle. You familiar with that? You just go like that, and hopefully things will part for you. First time I come to Vietnam many years ago, my wife and I were trying to cross an 8-lane highway in Hanoi, and we were just standing there, we just couldn't get across. And this little 80-year-old Ho Chi Minh guy saw us, our predicament. He had white hair and a white beard. And he just came up to us. Oh, okay, I've got to go on the stage. And he saw our predicament, and so he grabbed my wife and my hand and just plunged us into the traffic, you know. And we figured if he's lived this long, he knows what he's doing, you know. And so away we went, and just went like that, and all the buses and trucks stopped. So you get used to it, but it's still dangerous. I've also Vietnam's my second home, and I've got many friends here, and they've become part of my family. And I've got my Vietnamese local support group up the back for if I have any imposter syndrome anxiety. Sung Tu over there, so Sung Tu runs a tour business, so quite a remarkable lady. She's got 3 vegan restaurants here as well in Da Nang and Hoi An, and a small vegan cheese making facility as well, which is fairly new in this country. So quite an entrepreneurial lady, Sung Tu, over there. Okay, adolescent concussion. I've been a paramedic for about 45 years, MICA, intensive care, for 23 years. I was initially a medical scientist, but laboratory life was boring, so I got out of that. Didn't have enough funds to be a doctor, couldn't afford that at the time, that was pre-HICS, so I guess it's the next best thing. Also a bit of history, myself and 4 other MICA paramedics back in the 80s, we started the first pre-hospital emergency care conferences in Australia, so similar to what these guys are doing. Thank you. We ran 7 of them, 7 years running, up at the A&A Hotel up in Queensland, down at Hobart and in Melbourne. We flew speakers in from overseas, we did it all on private finance, we had sessions, we had workshops. The thing that I'm proudest about is that we introduced the concept of evidence-based practice and research in pre-hospital care, which sort of wasn't the thing back then. Okay, so I guess what I'm getting at is that I'm still involved in that sort of stuff. I just love, I guess because of my science background, I still love research and pre-hospital care. So I'm sort of semi-retired. I do mainly, what I call locum work, I suppose, freelancing. I was clinical manager for a private medical company, and that's where I sort of developed, had an interest in concussion management because a lot of our medics were dealing with sports. Australia being a sports-mad country, football, whatever. Had a lot of concussions, so every weekend there was multiple concussions. And so we developed, I'll show you a little bit later, we developed a uniform approach to assessing and managing concussions. Concussions has been done very, very badly in Australia. We are way behind the rest of the world. So the US and Canada, for instance, has led the field in concussion management for quite some time, but we're rapidly catching up. I'll have a go at ED physicians as well. Maybe not ED physicians, but ED departments in Australia. They have a lot to improve upon in concussion management. They're very good at dealing with the initial trauma, doing head injury obs, neuro obs, CT scan, etc. But that's the end of the story. So there's no, or very little management after the concussive event, which is very important, and hopefully I'll be able to bring that across today. Okay. It's not going? Yes, it is. Okay. I'll go back a little bit before I get onto that. I'll just give you a case example. I had a phone call from a father in Canberra just 2 weeks ago, and I live near Melbourne. And so I didn't know how so I guess word got out that I'm sort of very familiar with this. His 18-year-old son was participating in a motocross event and sustained his 12th concussion at 18 years of age. And he was very concerned, so he somehow got my name because I'm involved in leading teams to motocrosses, and I guess through the industry he got my details. He said his son had no LOC, GCS 15, but had a lingering headache, a persisting headache, nausea and visual disturbance, so it wasn't resolving. They took him to ED at Canberra Hospital. They did all the good things there. They did neuro-obs, looked after him. They did a head CT. That was all okay. And then they said to Dad, just give him 2 weeks off. And that was it, okay? So we are very, very bad at managing concussions post-ED admissions. And again, that's reinforced by we're doing follow-ups with a lot of patients, and that's the same story that we get consistently. So hopefully, ED physicians in here that, you'll perhaps give a little bit more importance to managing concussions. Okay, these are real-life examples, mostly in the American field. Thankfully, we haven't had any deaths in Australia that I could find. This young fellow, 15 years of age, sustaining a concussive event, blurred vision, headaches, seen by a doctor, sat out for 1 week, cleared the play, and in his third day back, lost consciousness and died. The 17-year-old, helmet-to-helmet hit in a game, sat out next week with headaches, returned the following week, and again, when he came back, he felt weird and splotchy, slipped in a coma and was pronounced brain dead. This is just a few. There's many examples of children, adolescents dying. Does this need a new battery? I'm just pressing. No, this thing. It's just not advancing. Okay. Oh, the enter. Okay, that's one. Which arrows? Oh, which arrows? Oh, yes, that's a big issue, particularly in your country. That's yeah, it is. That's actually in my next few slides. I'll talk about that. Yeah. Yeah. No, feel free. Thank you. All right, another fellow. Did we do that one? Okay. Sustaining a concussion, cleared by doctors to play. And I'll talk about the clearance by doctors and GPs as well a little bit later, because we generally don't recommend that, but for specific reasons. So he looked sluggish. He died the next day of bleeding and swelling in the brain. Rowan Stringer, a female in Canada, she died as well, led to a scathing coroner's report and enactment of Rowan's Law in Ontario, Canada, mandating concussion procedures in education. Now, all US states and provinces in Canada have mandated concussion laws for adolescents. We don't in Australia, okay? I'll come to there's a parliamentary inquiry back a few years ago, and that led to recommendations. So you could probably say that that's pretty strong, you know, in lieu of the laws. You wouldn't want to sort of go against those recommendations, and I'll show you what they are. Okay, so I'll talk about what is concussion, why focus on adolescents, and why there's been a generational change in attitude, and how we developed groundbreaking pre-hospital concussion management protocols for our medics out in the field when they're dealing with sporting injuries. And this is why, because there's a lot of confusion. How do you define concussion? What do you look for? Do you look for specific symptoms, or is there an easier method of determining concussion? So it's defined as a mild form of traumatic brain injury, GCS score between 13 and 15, and there's many causes, and this focuses primarily in adolescent concussion. And we don't define concussions as mild, moderate or severe, because mild concussions can persist for years, a long time, even though the initial symptoms might resolve quite quickly. Yes, well, the initial concussion symptoms might be similar. Repeated concussion in adults or multiple subsymptomatic head strikes can lead to TCE, particularly in adults. Okay, so there's actual histology associated with that, but of course that's only evident on autopsy. But with adolescents, there's no obvious histological changes or imaging or via biomarkers at this stage. So there's no lab sort of experiments or assays that to determine whether somebody has concussion in adolescence. But there's a greater propensity to sudden death with adolescents, particularly on second impact syndrome. Any people heard about second impact syndrome? Only a few? Oh, good. I didn't know whether to go home or not. Excellent. So it's been recognised as a significant medical issue, highlighted by short and long-term memory, cognitive and psychological trauma, potentially permanent consequences, particularly in adults that have multiple strikes, football players, NRL players, etc., leading to chronic traumatic encephalopathy and massive liability issues in the NFL in the US, highlighted by the film Concussion. Anybody seen that with Will Smith? Yeah? Okay, a great movie. And determining, looking at biomarkers, biochemical changes is an evolving field at the moment. It's a fascinating field. And a recognition now by sporting bodies in Australia that we need to do something about concussion management. Okay. In the US, there's been billions now set aside for NFL players due to long-term concussion consequences. And it's becoming a big issue here. So our AFL players, football league players in Australia, since the 27th of March this year that came out, okay, no insurer will now touch an AFL player. Okay, they've recognised the liability issues. So Zurich was the only company that would provide insurance for AFL players, and now they've pulled out, so there's no one. So the AFL has to accept their own liability. So that's how big an issue it's become. That's the film, so that's available if you want to have a look at it. It's a fantastic story. How the industry tried to debunk a pathologist in determining CTE. He was trying to show that there were histological changes from repeated concussive events, and the industry tried to debunk him and run him out of medical practice. So it's thought that the adolescent brain's at greater risk because obviously it's a developing brain, it's still forming neural networks, etc. And when they have a concussive event, they take a lot longer than adults to recover. Second impact syndrome, it's a fairly rare condition, but still, as I've shown you before, you don't want it to happen. A fatal condition that develops because of two separate events. So initially, there's a concussive event that tends to resolve itself over a period of time. However, the brain goes into a healing mode, and whilst the symptoms may resolve, the brain may still be healing for quite some time. So it could be weeks, months, and even years. And if that child has a second concussive event during that healing phase, that could lead to second impact syndrome and sudden death. Okay? So we need to recognise or move towards more of the management phase of concussion in adults, as well as treating the acute phase. So the second impact does not need to be forceful and can result in massive swelling of the brain and leading to massive neurometabolic cascade, which I'll just touch on a little bit later. So the first hit is considered less severe than the second because of the internal regulatory system the brain has, so autoregulation, the brain tries to fix itself, but that can take time. But during the healing process, that autoregulation is lost for another concussive event. And so there's greater vulnerability to traumatic brain injury and sudden and second impact syndrome. Okay, the second injury during healing process decreases autoregulation flow to the brain, and you get increased swelling of the brain and possible sudden collapse and death. We're all familiar with coup and counter-coup, how concussions occur. Just a reminder that it doesn't need to be a head strike, it can be a body strike. Okay. I had a motor vehicle accident 2 years ago, suffered a fractured sternum, okay, no loss of consciousness. I extricated myself, the vehicle was a write-off, but I've suffered extreme fatigue for 2 years after that. It was presumed that you need a significant amount of force to fracture your sternum, and so there's possible, significant body shake-up, and it was presumed that I had a significant concussive event leading to fatigue issues. The brain's grey and white matter have different densities, structurally damages the cells. As a result, millions of nerve impulses fire all over the place. Increased excitatory phase of acute concussion, and that explains the symptoms of confusion, dizziness, headache, and even loss of consciousness. There's a Gieser and Hovda are two neurobiologists in the United States. This is a very crude schematic, but it shows that there's structural and functional effects in the brain. The laser pointer doesn't really work, but you can see there's significant changes within the neurons. So massive amount of calcium shift, potassium shift, glucose, glutamate changes, and glutamate's one of the main excitatory neurotransmitters. But down here, most significantly, you can see reduced cerebral blood flow, and that can persist for quite some time. Calcium is very important for maintaining neuronal homeostasis. And neurons maintain low intracellular levels, so it's very essential for neuronal function. And mechanical impact disrupts cell membranes, leading to massive calcium influx. Blocks ATP production, mitochondrial dysfunction, causes an energy crisis in the cell, impairs cellular processes, and can prolong concussion symptoms. Brain consumes 25% of total ATP, powers the sodium-potassium pump, and the calcium influx disrupts ATP production in the mitochondria, but you need ATP to pump out the calcium, so you've got a vicious feedback loop happening there. So impaired ATP obviously can't get rid of the calcium that it wants to get rid of. Again, this is a very basic schematic. I'm not going to go into the biochemistry of what happens because you can dig yourself into a bigger rabbit hole. It's quite complex. But essentially, I haven't got a laser pointer, but you get massive influx of calcium, potassium out, mitochondrial dysfunction, ATP disruption, citric acid cycle disruption. You get axonal injury due to the shearing forces of the concussion. An inflammatory process gets set up, and also at the neurotransmission end, you're going to have a lot of disruption of AMP and MDA receptors and glutamate and GABA dysfunction, and the recycling process of the neurotransmitters is disrupted. So you can have a lot of effects from concussion. There's a bit of a list there: cortical demyelation, etc., apoptosis, glucose transport disruption, oxidative stress, inflammatory cytokines, etc. I've just got to rush through this a little bit, and a whole lot of changes which can occur. Again, a little bit about the glutamate and the GABA neurotransmitter functions. So glutamate's very important as the main excitatory neurotransmitter, and the GABA acts as the brake. And with concussion, that whole thing can be turned around in the opposite direction. And we'll look at also neuroplasticity, because this whole thing affects neuroplasticity as well, you know, and how they, in terms of memory, creating memory. Again, just a graphical representation of the GABA glutamate cycle, how it can cause a whole lot of changes within the brain. And this is just an evolving field still, all right? So it's something that's sort of only been developing fairly recently. And again, at the synaptic terminals of the neurons, we get significant alteration of and disruption of the neurotransmission pathway and the recycling of the neurotransmitters. There's a thing called long-term potentiation and also long-term depression. So that generally refers to neuroplasticity, the developing of memory. Generally, long-term potentiation is where due to increased activity, the brain learns, okay, improves skills, etc., motor function. LTD, neurodepression, is the brain's method of pruning the neuro tree, for want of a better analogy. You know, so if you're not using something, the brain sort of works at removing those sort of connections. Again, in concussion, they propose that whole thing flips around. So, yes, synaptic plasticity is activity dependent, and that whole process is flipped on its head again. So now we go to the clinical side of things. So the symptoms might be many, okay, and they're quite unique to each individual, and a general term we have is not quite right, okay, so it doesn't need to specify a particular symptom. If they're not quite right, or they're somehow different from pre-impact, that's a sign of concussion. The Sports Concussion Assessment Tool, SCAT-6, I'll talk about a little bit later, but sort of categorises the various types of symptoms into these 4 categories: so physical signs, cognitive signs, emotional signs, sleep disturbance. This is interesting. No offence, but particularly dealing with teenage girls. Play a lot of football now. The teenagers, girls play a lot of contact sport, and you know, as they're growing up, you commonly hear from parents that they'd like to bury them and resurrect them when they're 22 or something like that. So sometimes it's very difficult to know whether emotional lability is due to a concussion or that's just their natural mood changes. And we'll talk about girls a little bit more later, because they affected differently by concussion than what males are. Sex differences, so females are more prone to concussion effects. The axons are different physically, they're anatomically thinner and more flexible, greater calcium flux post-axon stretch than males, and increased time frame of persisting symptoms. And I used to do a lot of follow-ups of people that had concussions. So I'd ring up their parents, etc., to find out what happened in ED for a start. And we've had girls that even months down the track are still affected by the concussive event. Months down the track. This is a fluoroscopy done of in vitro human male and female cultured axons and also rat axons. And what the fluoroscopy shows is the increased calcium flux in females, both in rats and in vitro cultures of human axons compared to males. So there's significant structural and functional changes. So there's no need so after you hear this, it doesn't mean you wrap your kids in cotton wool and tell them not to play football anymore. Okay, there's no need for alarm, it's just about recognition and management. And clinical evaluation in the field. Okay, so what we've done is we have defined concussion as mechanism plus one. It's either yes or no, and that's concussion. You don't need to look for any other signs and symptoms. Mechanism can be just a force applied to the body. It doesn't need to be a head strike, it can be a body strike as well. If they have that mechanism plus one, and it can be not quite right, or any other symptom that wasn't there before, that's concussion. So you don't need to go through a list. Yeah. It's either yes or no, and that's it. And once you've reached that stage, they're out. Okay, they stop sport. They don't play again. Okay, and we'll go through the recovery mechanism. So our management's immediate removal from activity and no further contact activity until cleared. Obviously, you deal with the serious red flags. You look for any neck pain, any other bleeding, etc., etc. Your primary survey, secondary survey, etc. Make sure they're okay. In the first 24, 48 hours following concussion should be a period of relative but not strict rest. And Rob will agree with me there. Okay, we actually encourage light physical and cognitive activity that does not exacerbate symptoms, but it may mean that you take the screen away from them. It's called brain rest. So reduce the amount of screen time, the time on their phone, and perhaps contact their school and reduce the school workload, the homework, etc., etc., so that you're giving the brain a chance to rest. Allow sleep, no alcohol or recreational drugs. Pain relief, obviously we don't want aspirin or ibuprofen, just paracetamol and codeine. Light cognitive activity and recommendations not to drive in the first 24 hours. After 48 hours, return to daily living in a graduated manner, no contact sport until all symptoms are resolved and medical clearance, and that's something that we'll deal with. Most adolescents fully recover within 10 to 14 days, but maybe up to 4 weeks or more. Okay. And in Australia now, the minimum recommended recovery for adolescents is 21 days. So that's it. You're out for 21 days. Doesn't mean you can go back after 21 days, but you're out. Okay. And then it may mean that you need further rest time. Forced rest prolongs recovery. But there's also a study which shows that mild exercise actually aids in rehabilitation. Not to the extent that you're pushing your body, increasing your heart rate, doing those sorts of things, but just mild aerobic exercises tends to be beneficial. Persistent post-concussion symptoms, which last for more than 4 weeks, may affect up to 53% of concussed patients, and each person's concussion recovery speed is unique to them. Research indicates that the persistent concussion changes may increase with age, with adolescents and older adults and females, longer period of recovery. All right, so this is what we developed. This is what we give all our medics. This is a paper-based copy, so that we adopt a consistent approach for concussion out in the field. So I'm quite proud of this document. So we go, just very quickly, we go through the normal ABCs when somebody's injured. Our medic makes sure, looks at the conscious state, etc., etc. Then Then we apply 3 criteria. And the 3 criteria is take them off, no contact sport, evaluate them, make sure everything else, their vital signs, things all okay, they haven't got neck pain. And then we sit them down for about 15 or 20 minutes, okay, and just observe them. If their concussive symptoms are completely resolved within that 10 or 15 minutes, we recommend that they can go home, okay, with their parents, provided their parents just watch them closely for the next 4 to 6 hours or so. If any change, call 000. But with the proviso that they go the next day or as soon as possible to get evaluated for their concussion, okay? If during that 15 or 20 minute window, their concussion symptoms are resolving, however not completely resolved, they go straight to ED, okay? Now that can be by private means or ambulance, quite comfortable to send them with private means, provided the parents go straight to the hospital and not to McDonald's on the way. Because you don't really need the ambulance for routine transport like that, but they've still got their symptoms. And obviously the third action that we have is that within that 15-20 minute time frame, the symptoms are not resolving or getting worse, then they get an ambulance and go straight to ED. Pretty simple. Works really well. So now we have a consistent approach for concussion management. We also give the parents a fact sheet, a concussion advice sheet, because we found that once they leave the ground, we have no further control. And sometimes in the heat of battle, you know, it's hard to get the information across. You might have multiple patients, etc., etc. So we give them a fact sheet. Right? It explains briefly what concussion is, what they should do next, okay? And we ask them that they get assessed. Now, we specifically stay in there that we do not recommend they see their GP. Apologies. Generally because GPs are not expert in concussion management, and it's a time-consuming process, okay? We prefer that they're referred to a sports physician, someone that specialises in managing concussion. You GPs happy with that? No? You think you can manage the post-concussive event? Yeah. That's fine. I mean, this is just a recommendation. What we're trying to emphasise, however, is, again, we've had a lot of experience where they've seen a GP. The GP's just done a quick evaluation. They haven't done a proper SCAT-6, which I'll talk about later. They haven't adopted a proper management plan. They've just basically, again, said, just give him 3 weeks off, and if he's okay, he can go back to sport. So that's what we found. Not saying all of you do that, but that's generally what we found. So we just want to make sure that they're receiving expert care. It's not... Yes? Oh, I agree. And that's what I said at the start of the talk, that the ED departments in Australia manage concussion very poorly. Very poorly, yeah. So I agree with you there. Of course it does. I'm generalising. Yes, I'm generalising, okay? And this is based on follow-ups that we've done. So even that first case that I spoke to you about just recently in Canberra Hospital, a couple of weeks off was all the advice that he got, no management plan. When I followed up on other people that we dealt with, the same sort of thing. For yourself, you mean? Yeah, and I'm happy to send it to you. Yeah.
So I work remote.
Yes.
And a young male teenager that had a concussion 6 weeks prior whilst playing basketball. He came into me, I was like week 7 after the first concussion, given another concussion, but he had worsening symptoms. And I'm trying to explain to a doctor over the phone, he's got worsening symptoms of a previous concussion.
As I said, in the US and Canada, they actually have mandated laws, so every state has to have a formal process. So whether that means they see their doctor or whether that's escalated to a higher level, I'm not sure. You'll see in the parliamentary inquiry we had some quite decent recommendations that the parliamentary inquiry made. So yeah, it's not denigrating GPs. We just we know that a lot of GPs just don't have the time or the expertise to deal with this. Various concussion tools out there. This is just one that's used by first aiders. It just basically, is a tick box form to evaluate concussion on the field when there's no medical trained individuals around, so sports coaches, etc. The Murdoch Children Research Institute have developed an app, so it's a self-management app. It's a brilliant app. A child, with the help of an adult, depending on the age of the child, can download their particulars from the app. They can put in their normal cognitive state, their sleep pattern, etc., and then their concussion details. And the app will then work through a recovery program automatically. So it alerts the patient every day and gives them particular tasks to do, and then it measures those tasks and see how the person responds. And based on those responses, it advances those tasks or takes them back. Okay, so it's a self-management tool. It's brilliant, and you get alerts. The person gets alerts every day to see what their progress is. So you can download that app yourself. It's a brilliant initiative for those that want to self-manage. So it's an evidence-based app, and it also provides It provides feedback. It provides data back to the Murdoch Child Institute, but with de-identifiers. I'll just flick through this. How are we going for time? Okay. So I'll just flick through this. So there's all various features on the app, but it's brilliant. Even after they see a GP, for instance, then if they have this app, then they can sort of, in conjunction with their GP, they can perhaps monitor their progress through the app. So it's another tool that's available. And obviously, if you're not recovering appropriately, it then recommends that you seek further specialist care. For those that are in Melbourne or in Victoria, there's the Royal Children's Hospital for anyone that's aged 8 to 18. They're happy to see a concussed patient totally free of charge. So that's another. Otherwise, there's sports physicians. There's a number of sports physicians which specialise in concussion. And the Australian Institute of Sport, for instance, also provides concussion clinics. Now, this is a tool that's been commonly used. So this was developed by a consensus statement of neurologists around the world. What's called SCAT-6 at the moment, version 6, Sports Concussion Assessment Tool for children 13 years or older. It's about a 9-page assessment, and there are other versions for younger children as well. The target audience is for children 13 and older. Mainly recommended for within the first few days of injury and up to a week post-injury, but after about 7 days it tends to lose its relevance. There's a new tool being developed called the SCOAT-6, so that sort of takes over from the SCAT-6. So that's more intended for long-term assessment and rehabilitation. Kick in the bucket. So the SCAT-6 maximal utility occurs within the first 72 hours and diminishes, and has limited utility as a return to play. So it does a lot of cognitive tests. Essentially, what the tool is, a lot of cognitive tests, and assess the person that way, and then has recommendations of how they should recover. So the SCOAT-6 is a longer time frame assessment tool. What we're trying to get at with these tools is when can the child go back to sport? That's the thing. Is it safe? They may be symptom-free, but they still have some cognitive dysfunction, vestibular dysfunction. They still may have consequences from the concussion, which the brain hasn't quite healed yet. Okay, so 2023 we had a Senate inquiry into concussion, okay, and they made landmark recommendations, so you can sort of treat them as de facto laws, instead of enacting laws as such, so you'd be pretty wise to sort of follow those recommendations if you're involved in sporting associations. Mandatory 21-day stand down, that's the minimum, non-negotiable. You don't go back to contact sport, that's the minimum that you do. Establish universal, consistent protocols for return to sport, even with the football, etc. The adult games. Mandatory reporting and documentation to a central database. A national sports injury database be developed. Evidence-based guidelines ensure all concussion management is guided by the latest scientific evidence, particularly the 14-day symptom-free requirement. That clashes a bit with the 21-day, for adolescents it's 21 days. Rule modifications, which is a tough one in contact sport. How do you change the rules? It's contact sport after all. So implement rule changes to reduce the overall number of head impacts in contact sports, and of course the AFL, is grappling with those very issues. Specialised medical care, okay, are reviewed by professionals with specific expertise in concussion management. That's so for the GPs out there, that's the recommendation. And improve support services, so financial medical support for athletes suffering from long-term effects of repeated head trauma. Targeted care for women and parasports people, because the effects are greater on females. Appoint dedicated concussion officers within clubs to manage the implementation. That's a significant change. If you're involved as a volunteer parent within a sporty body, it's a wise thing to maybe consider. And enhanced education, which we're battling against at the moment, because you have it in a lot of sports. You have the old coaches, they're still old. Take a spoonful of concrete approach. You'll be right. Just sit down for a few minutes and you can go back in. We still have that. We're still fighting that in the junior sporting field. And early intervention. Independent experts, so you're reducing conflicts of interest. Have independent doctors rather than club-appointed doctors. There were some recent issues regarding that within the AFL, within one club, where a player went back earlier than what was recommended based on the club doctor recommendation, and of course that was overturned later. I think that would be fairly rare. Most doctors have the interest of the patient at heart. So the key takeaways from this talk is concussion mechanism +1, yes or no. It's very simple, straightforward. Helmets have no impact on concussion because it's a concussive force on the body. Helmets make no difference at all. We don't have a concussion grading scale, so there's no such thing as mild, moderate or severe. It's just concussion. And the effects on the brain may be abnormal well after the symptoms have resolved. So that's another thing that, you can't equate resolution of symptoms with healing. The brain may still be in the healing process. That's why there has to be a proper assessment management post-concussion. And no return to contact sport until all symptoms are fully resolved under a recognised concussion management plan and recognise the long-term consequences of concussion, such as CTE and things like Alzheimer's, dementia, etc., which may be attributed to concussion. Any questions? Well, my work that I do at the moment, I'm heavily involved in the military. So I do a lot of defence work and also with the police bomb squad, so that's not photoshopped. That's, yeah. Any questions at all? Yes?
Like with the paediatric, the self-assessment tool that you showed up there, we know that children can be quite mischievous and you're telling them away from sport for a prolonged period of time. Do you find that they will have game the answers so they can get back faster or anything like that with a self-assessment tool, not utilising a sports doctor, GP, whoever?
Well, ideally it should be done in conjunction with the GP. So, I'll give the GPs that they should see the person and then go through this process. And depending on the age of the child, I'd suggest that the parents be part of the process as well. Is that what you're sort of... The app is, you can download the app and you can also do a dummy run yourself, right? I downloaded the app many months ago and I'm still getting alerts every day for me to fill in the boxes, yeah? And it'll progress you along, and then if things aren't working out, it'll push you back or hold you, right? And if things still aren't progressing, then it's advising you to seek professional care. It doesn't... Why? I know. That's why probably you need... I deal with the kids all the time, particularly in motocross. They want to get back on the bike in the next race, and I said, no, you can't, You just can't. At the end of the day, all sporting codes to absolve responsibility just needs a doctor's signature that the kid can go back. It doesn't need to be from an expert. As long as there's a medical officer who's cleared to come back, that's all that the sporting bodies want. Yeah. Which may not be right, but that absolves them of any responsibility and puts it back onto the doctor. Yeah.
So is there a cost factor involved, like you were talking about, GPs versus sports specialists?
Yes and no, but most sporting bodies have insurance, and when you put your child in to play a junior sport, you pay a fee, and a part of that fee goes to insurance. So,
if you want to see a sports medicine physician, you have to pay to go to the
yes, if you see a lot of the sporting institutions have junior doctors that are there, and that's generally free of charge. If you want to see a higher level physician, then there's generally a charge associated with that, but again, the insurance would cover that. So long as you get a referral. Yeah, that's the main thing, yeah.
Is there any evidence to support the use of kind of pre-injury baseline cognitive profiling? There's a lot of places seem to be using now, like screening all their players, getting a kind of baseline cognitive assessment in anticipation of concussion. Is that useful, or is that just people?
Well, I hadn't actually thought of that. That's a good question. Rob, you got any things on it? Rob annoyed me yesterday because he posted a adolescent concussion thing on his famous Facebook thing, and I got up in the morning and I looked at it and I said, "Hey, this is my talk." I said nobody's going to come to my talk today. So it was purely coincidental. But what Rob has written is almost sort of a copy of what I've done, and it's good. Obviously, it's fantastic to promote the awareness of concussion out in the field. So, he's done a fantastic job. But no, I hadn't thought of that, so I can't say. I can't contribute to that at all. That would be quite... I can't imagine junior sports. So we're talking about adolescent concussions here, volunteer parents, etc., etc. I can't imagine them doing that. Sorry, hang on. Sorry, go. Oh, really? Could you send that to me, please? That'd that'd be great. I haven't heard of that. No, sorry.
Could I ask a question?
Oh, sorry.
Sorry, if you've got teenagers and their parents are wicked, wouldn't you be asking the parent this is normal for their child, the way they are?
Yeah, well, the situation we're dealing with is junior. We have medics at junior sports, so every football and ground in Victoria, junior sports has a medic. So they're generally first aiders, right? But obviously we do CPDs on concussion, so they know what to look for. They have the format that they have to follow. So they're just watching the field, they're watching the action. So hopefully they're watching the hit, the mechanism that's been applied, and then watching how the child responds. You know, if they're sluggish in getting up, walking, holding their head, then off they go. And so we just deal with the immediacy of that, okay, and then go follow those 3 action plans that we have, sit them out, you know, watch how they go, how they recover, and then we talk to the parent about what should be done next. Yeah. Yes?
Last question, sorry. Big voice.
Nothing. There's nothing available. CTs, MRIs don't show anything. With adolescents, yes, but with adults with traumatic encephalopathy, which has developed over many, many years, you actually get histological changes, yeah, which may, if it's severe, be picked up by imaging. Otherwise, it's picked up on autopsy, unfortunately. Yeah.
SPECT scans and PET scans wouldn't find it?
I don't know specifically, but just as a general comment from everything that I've researched, imaging does nothing. Nothing for concussion. And again, I mean, you know, with concussion, you're only dealing, you know, EDs in reality, you're only dealing with the immediate acute phase, yeah. No obvious brain bleed, etc. And then, do you really need, is then imaging later or after that, like you were describing, going to be of any benefit? Because you're still going to manage them based on their symptoms, yeah.
Just a real quick comment, sorry. Because for school-age kids, we require a physical before they play any physical contact sport, and cognitive has been added to the physical.
Right.
So
Okay.
they just added it as a requirement.
Yes.
As part of the physical. So
But-
consider that as part of, if you're looking at changing process, put it as part of the actual physical exam to play the sport.
Yeah, Bill's from the US, as you can probably tell.
I did not vote for him, I'm sorry.
Yes. I suggested you get a badge saying it's not my fault. Yeah. So I hope that sort of changes your perspective for those that are involved in adolescent sports, contact sports a little bit, to really take concussion seriously, particularly post-concussion management. Rob, you want to say anything else? You okay? Yeah. All right, thank you very much.
Thank you, Eb. And apologies we had to cut the questions short. I think it really shows it's quite a topical presentation, so really appreciate you coming along and talking about it. We've talked about a bit of stuff this week. We've looked at what's happening in Australia, New Zealand, Vietnam. I bet you're all wondering, what about South Africa? So, thanks to Louis, we can now find out a bit about ambulance and crit care in South Africa. So let's hear it for Louis. Come on down.
Cool. Thanks, Quentin. Good morning, everyone. First of all, I don't know how this is going to go because someone in the lift asked me, what does your flag mean? And I said, I'm not sure, but I know blue is at the bottom because that's the ocean and red up top because it gets really hot in South Africa as well. I don't know the complete background. I know there's a big story to it. And the colleagues that's watching online, I apologize in advance. Also, I don't know if you are the lucky crowd or this is going to be kind of like torture, because this was my PhD work. So for myself, it's a little bit of torture, I guess. And this is kind of not going to take a normal research lens when we look at the talk. So I'm going to kind of show you a little bit of what we have in South Africa, an overview of our EMS system, specifically in the Western Cape province where I'm from. And then I'll go into how we've done the study and the things that we looked at to try and formalize critical care retrieval services within our space. So that's me. A little bit of an introduction. You can probably see that I'm very happy there because in October last year I returned back to Western Cape EMS as a deputy director for them, where I'm supposed to be looking at provincial governance, quality assurance, and then kind of a little bit of performance intelligence across our space. I am still figuring that out as I'm going along. Also, my other kind of roles that I play, I am an honorary lecturer for the University of Cape Town in emergency medicine. Not so much in the tutor space anymore, but more postgraduate supervision and curriculum development within some of their programs. As of April last year, I've been voted as the president for the Emergency Care Society for South Africa, so that's quite new as well. And then in the research space, I am an associate editor for the African Journal of Emergency Medicine. So that's myself in a professional capacity. Let's get into the talk. The first few slides will be an overview of our system back home, and then the latter part of the presentation will go specifically look at the PhD part. Also, my home language is Afrikaans, so the English sometimes kind of disappears as the presentation goes along, but I'll try and stick to it. So as in any public sector, I think we are an extremely high volume system. We face between 600 and 7,000 incidents annually. We have 52 EMS stations. If you look at the red kind of heat map area, that's Cape Town and the metropole. So we've got 4 mega stations in that space, which generally runs 15 to 20 ambulances per day. Varies between night and day shift, depending on how busy we are. But then for the majority of the province, which is a total of 130,000 square kilometers, we have 1 or 2 ambulance stations, which significantly poses us a problem because if we move out of that specific town, that area will be without an ambulance for probably up to 3 hours, if not more. Operational staff is 1,500 more or less. And then interfacilities is becoming a huge, huge problem for us simply because we've got a tiered healthcare system. And I don't think that's unique to South Africa. So you've got community-based healthcare, you've got regional healthcare, and then specialist facilities. But in smaller towns, this is becoming a real kind of pressure, and we're trying to figure out how to deal with that. In the metropole space, specifically Cape Town, I'll show you a photo just now. Up to 40% of our daily cases is interfacility transfers. So it's not just emergency care work as we know it. That's kind of it. This is us. South Africa has a nationally kind of regulated uniform, so everybody in green is in a public ambulance service. That's where I've been working for all of my career, except a 2-year break within the National Department of Health. Yeah, that had its own challenges, and then I moved back into the provincial space within Cape Town. We also operate within a pluralistic system. So it means we've got public healthcare, we've got private healthcare, and then we've got NPOs that play in the game. Gentleman in the middle there with the navy kind of jumpsuit is from a private ambulance service. So we kind of work hand in hand to render the emergency services to the public. We also got helicopter emergency medical services. Currently in the Western Cape, we only have 2 helicopters, one in Oudtshoorn, and I'll speak a little bit about that, which is a rural space, then one in Cape Town, and then we also have fixed wing capability. But due to inclement weather, our helicopter is basically not able to function as much as it should on a daily. We also have specialized rescue services as part of our ambulance service. So they kind of do what fire and rescue should do, but more on the medical side, so extricate patients, those kind of things. And then we are very fortunate to be one of the only provinces to have, well, not one of the only, but one of the few that is registered and got our own training center that offers up until the diploma level of qualification for emergency care. So that's quite cool. I think so. I don't know if you do. Then just a bit of background. This is kind of what we face. Really poor informal settlement on your left-hand side, and then a fancy state on the left-hand side, informal settlement on the right-hand side. Similar kind of picture. Vast differences in socioeconomic statuses in South Africa. This area up here is called Izamayetu. It's an informal settlement in Hout Bay. And every year, basically starting from now, because it's winter, it will flood. And then we won't be able to access our community in that space. for our clients, and then during hot summer seasons, it will actually flare up and burn down. And this was during a fire. You can actually see the top corner there where some of the housing has been destroyed. With that being said, because we've got private services and public services operating within the space, if you're fortunate and you're in the private space and you have a medical aid or an insurance, you'll probably get an ambulance within 15 to 20 minutes. If you sit in the public space, you might often wait up to 4 hours, if not longer, depending on what your emergency is. So there's a vast disparity in that space. Then also, besides the socioeconomic things, then we've got the metropole area, and this is an area in our West Coast space, which is called Pitterfontein. It's really small, one ambulance. If they move out of there, there's no ambulance for 4 hours. And the other healthcare facility in the town is a community-based clinic. So there's really kind of disparities in that as well. On the other side, where my office is, somewhere around there, resource abundance, a lot of resources focused on one call often, and generally kind of spoiled if you're in that space. If you move out of the city, not the reality. A little bit of how the qualifications look in our space, and I think some of the Australian paramedics or EMS professionals might be aware of this. In the past, we had basic life support, intermediate life support, and then in the middle is advanced life support paramedic. That was a short course structure. It's been phased out since, fully phased out since 2017. Before that, it would have been a 1-month qualification with some on-the-job hours, the next qualification, and then lastly, the paramedic as we all know it. We've since professionalized, actually a couple of years already. The higher certificate is the newest qualification on the block. So that's a 1-year qualification, and you become emergency care assistant. So basically the partner of the paramedic or the person on the ambulance. And then this has been up and down. When I did it, it was a 3-year diploma. It went down to a 2-year diploma, and it's back to a 3-year diploma now again. So someone in the educational space is kind of a little bit undecisive. And then we've got our 4-year professional degree, which kind of leads you to be an emergency care practitioner, or if you look at probably in your space, an advanced care practitioner. That's it. So, and then of course on top of this, there's master's qualifications and the PhDs. The only difference in our space from I guess, to Australia and some other international spaces is our master's doesn't generally lead to some sort of specialization. So we'll do a master's, it's a generic master's, there'll be a research component attached to it. Mine specifically was in emergency medicine with a focus on clinical medicine, but I can't register it with the board to say that I've kind of specialized in this space. So that's kind of the difference that we have there. So very much research focused. So now, the study part. And I am cognizant that I'm in between tea. So I'll try and not keep you too long. So I think our current context on the far side of the screen, because we are a tiered healthcare system, we often see many patients transferred to specialized centers. Disclaimer, Notebook Alan made the slides, and it's US spelling and not UK, so ignore the Zs. Then, because we see the huge amount of patients that we move, specifically from a rural context into our cities or into our metropoles and specialized centers, we've kind of also picked up that there's a great disparity in the level of care that we provide to our patients, specifically the ones that is critically ill and injured. As an example, for context, the Cape Town space, which I've showed you the photo a little bit earlier, we've got a dedicated ICU team with dedicated teams, dedicated equipment, whose daily bread and butter is moving these patients between facilities in the city. If we go out to one of those rural places, you'll probably get a generic ambulance with a paramedic that's been trained a couple of years ago, not updated in ICU kind of standards, and they will be required to do either a 4 to 5 hour transfer and move that patient across the space. Through the presentation, you'll see these things in blue blocks. It's basically phrases that came up from the research that's been done. But in general, undergrad training for South African paramedics is focused on primary response, and I think that's the same in many other spaces. We don't generally focus too much on the ICU side of things, although we will get trained on ventilation, we will get trained on other skill sets, but that's kind of a by-the-by thing. Someone said put diesel. We probably get trained to put diesel as well a bit more often. Move your ass and get to the hospital. The next is just a little bit of a comparison between routine IFTs, and I think we're all familiar with that. specifically if you're in EMS, the routine kind of patient that's moved is generally quite stable. There's a standard dispatch. We'll log the call with the hospital. The hospital will log it with our control center. They'll get moved around. There's not a lot of risk. It's a routine thing. And then normally standard EMS practitioners would be able to kind of do those on the regular. The problem when it comes to critical care or ICU kind of things, the patient is generally just physiologically too unstable. And I don't know if you've noticed, but if you put them in an ambulance that often even goes further south, it seems quite nice and casualty, it's a controlled environment or healthcare facility, we put them in the ambulance, it's not the same kind of story anymore. So there's a huge risk of transport stresses in that space. And I think from the earlier talks this week when we spoke about siloed care and also the lack of communication, it's something that really kind of drowns critical care retrieval in our spaces because there's multiple stakeholders involved and we're not trained to work together on a daily. We've got different standards, undergraduate training is different, and then generally from a hospital side or facility side, it seems easy enough to say, yes, we just need to move the patient to the next facility. Doesn't mean that the stakeholder on the other side in green is able to do that to the best of their ability, not generally just due to clinical qualification, but also sometimes due to equipment constraints and distance and transport. And then I spoke about this already, and then we kind of came up with the idea to say, well, we'll probably need something dedicated in the postgraduate space to look at critical care. And not just for critical care, but the talk is focusing on that. So generally, the ecosystem of critical care retrieval, and I think it's for many other things, it's potentially for urgent care, it can be if we look at our palliative care patients, but again, this is not the focus of the talk. And generally, EMS is a complex adaptive system. So I don't know how many of us read about complex adaptive systems. We've recently started looking at it because EMS, for the longest period of time, since its existence, has been bogged down in time metrics when we want to measure ourselves whether we're good or bad. And that definitely doesn't show us anything besides we got there quickly. It doesn't show us what happened in the box in the back of the ambulance. It doesn't show us the decisions that's been made in the dispatch and coordination phase. And then also doesn't even point us towards patient outcomes. So if we look at CCR, critical care retrieval in that space, we probably need to look at it as a continuum of care from the community-based setting up until the point where we dispose the patient at the receiving facility. One space that is definitely lacking in the South African space, I know it's much more developed in other spaces, is our dispatch and coordination phase. We really don't do well with over triage, and I think you can imagine that in a low resource setting. If we over triage someone to say they a red or an orange or priority 1 case, it means that they'll probably end up somewhere in these facilities, and if they should not be there, we're taking a bed away from someone else. And unfortunately, if we look at the research in the South African space, we probably still sit with a 70% over triage rate. And that's literally just because of decisions that's been made in dispatch and coordination. So there's a lot of work that needs to be done in that space. Happy to say that we've gotten to a point where we have kind of standardized what critical care retrieval cases would be in our space. Again, we've got 9 provinces in South Africa which all operate independently. So we've adopted something, and it doesn't mean that the province across the line has adopted that. I think when it comes to this space, we're generally okay with the ambulance, but we still need to focus on dedicated training and dedicated crews for critical care retrieval with a dedicated set of equipment. Again, what makes it really awkward is if we have that high kind of case burden, which we do see on a daily, is how do we validate putting a really expensive resource that's probably going to cater for 4% of our patients, that is ICU kind of level patients, if the other patients is still kind of suffering, just not getting the ambulance care that they should. One thing that we also need to work on in our space, specifically back to dispatch and coordination, is who gets an ambulance. Up to 75% of people in the South African context that phones for an ambulance is phoning for transport, not for emergency care. Someone mentioned earlier this week about social support for taxi vouchers. We don't have that. We are trying to investigate it, but again, it's going to be a funding constraint, probably in our space. One fundamental thing that fails in the critically ill patient, and it comes up over and over, and it came up earlier in the week, is how we communicate and how we hand over. And I think that's something that we'll need to look at when we go forward. I see I've got 10 minutes left. So not to bog you down, I know it's really small, but just to kind of bring across that this is not something that I sucked out of my own thumb. There's a lot of work in the international space, a lot of it that's been happening in the Australian space as well. The UK space is also doing quite a lot of work in critical care retrieval. The US as well, but the EMS model is slightly different. And then back this side is the South African kind of things. And this has been coming for more than a decade. Some of this I wasn't involved in, and some of it I was, but essentially there's been work done in the Gauteng province, kind of speaking to general paramedics to find out how do they kind of feel about this. Are they comfortable? Are they equipped? We've done a little bit of work on what do we need to know? What clinical skills do we need to have to do this? Then there's a setting standard kind of work that's been done. And then again, there's some university level work that looks at how we move our patients that's critically ill and injured. Basically, it says that we suck and we need to get better and we need to standardize how we do things. So in a nutshell, the PhD consisted of 4 phases or 4 separate studies. And essentially, it kind of we tried to develop a contextually relevant curriculum for the South African space. And I think it's something that you can probably see out of your own lens as well. But it doesn't work if we just copy something from a high income setting and we put it into our space and we think, well, this is what we need to have to make it work. Some of the things, the clinical care, yes, we can, but the system-based things will probably be bogged down in. So we wanted something that was evidence-informed, context-specific, and expert-driven, and I'll speak a little bit about it. The first part was a scoping review. Then we looked at cases within the Western Cape province specifically. We did a little bit of a qualitative study following the Kearns curriculum development model, where there was a needs assessment, and then lastly, the Delphi. So the scoping review, self-explanatory, I guess. Definitely not a spoiler alert, but most of the data was from high-income countries. 95% of the things that we could find was from that. We've also seen that some of the international colleagues focus on kind of cross-trained teams. So it's not just EMS-based, where our teams are purely just EMS. You might be lucky in the HEMS environment where you'll find a doctor in that space or a nurse in that space. International systems is way more lenient when it comes to over triage. I also don't think so always. If you look at your ramping issues and similar ramping issues in the UK, probably not. But from our perspective, we would think it is. But if you look at evidence, probably not. And then even though the international space has kind of gone quite far with critical care, there's also no universal training model across, and it also differs between states and provinces and where you find yourself, and even sometimes services. Initially, I did the scoping review because I thought it's easier than doing a proper literature review. And when I started, I found 817 kind of pieces of literature, which was evidence-based, and some of it is gray literature. So for those of us that's not familiar with the term, it's anything you can find on the internet, newspaper articles or whatever that's not generally published. And once we worked through those, we ended up only including 59 of 59 of those studies. Then I took the time to look at 25,635 adult cases because we specifically focused on the adult population, simply because at that current stage there was work happening in a master's study somewhere else, so I didn't include the pediatric burden in this. For the critical care retrieval studies, we only looked at red and orange patients in our space because those were generally the patients that gets moved by our advanced life support practitioners. So just to kind of avoid the patients, and we kind of see if we can pick up the right subset of patients. We initially thought that we'll see an extremely high trauma burden because we stay in South Africa and it's quite violent. The data proved differently. We saw a lot of cardiovascular and respiratory kind of diseases. However, COVID was in here, so this was a little bit of a skew for us as well. Then we've seen, which we've spoken about already, that we often have EMS-led teams only, And I think our biggest issue is the resource constraint and how do we focus that training going forward in that space. The third part was the needs analysis, which was basically, it's one of the steps in the Kearns curriculum development model, where we spoke to supposedly learners, but those were paramedics already practicing in the field, and they will be potential candidates for such program if it comes to life. And then we also spoke to, so to say, experts, 10 years and more experience in our space we'll deem as that. And that was doctors, ICU nurses, critical care physicians, and then again paramedics working in that space. And we came up with 3 kind of concepts that our graduates said that they are not ready. We train them, we give them the badge, we give them the response car keys or the ambulance and say, there you go. They get out there, they're like, okay. I learned that as 21 years old. I probably didn't realize that I wasn't not ready. Probably an ego thing, I guess. And then insufficient training. So yes, there's an ICU module in each of our courses, but it's generally kind of brushed over. Or we also have a high turnover in lecturing staff. So today you get Louis teaching you something, and tomorrow you've got Quentin doing something, and they don't have the same standard and also not the same exposure. So that's something that we have a problem with. And then again, needs for standardization. Within the 4 universities in South Africa that primarily trains the degree level of practitioners, not one of them has the same curriculum when it comes to ICU. Not one of them has the same focus. So that's something kind of that came up. And then again, just a quote from one of the learners at the bottom. You can't be completely comfortable coming out of university. That's understanding. And they didn't prepare us what really happens in reality. The last part of the study was the Delphi part, which was done in 3 iterative rounds. We had 83 people kind of partaking in that. And then we had a 75% consensus threshold achieved. And essentially, it validated the finalized framework for the curriculum, the domains, and what we need to be focusing on when we train critical care in the space. There was 164 draft items. Only one item that could not really reach consensus, and that was something to do with feeds during transport and those kind of things, which our kind of core group of people didn't think it's that important unless you've got a really prolonged transport time. Oops, apologies. So the curriculum overview, really broadly, I'm not going to go into each of the learning outcomes and things that's been developed, but essentially there's some work that needs to be done in the clinical care space. And for us, the degree paramedic, generally the level of clinical training is sufficient, but there's things that is on top of that. So when it comes to special populations, and specifically when it comes to pharmacology, I mean, we all have our own scope, own list of things that we can give, and then often you get to an ICU and you have a patient with X, Y, and Z that it's attached to it, and we really don't know. We often end up Googling and finding out what's this agent, does it need to continue, can we switch it off? And what has been done a couple of years ago, you'll probably go to a facility and you'll ask the physician, which ones can we switch off? Because I only have 3 infusion devices. I don't have 5 or 6 as in the ICU. So there's a lot of work that we would like to do in the pharmacology space to expand that, not necessarily to say from a prescription point of view, but for us to actually have a solid knowledge to know what is important. Transport medicine, in the EMS space, it seems to be self-explanatory. But in the South African space, specifically in the emergency medicine space, we get a lot of EMS registrars coming to work in our space. Not comfortable with ambulance services at all, not comfortable with the road, and transport medicine would be something that we'll need to get across to them because they're trained in a hospital facility. Put them in a response car, put them in an ambulance, it's really not their space. We're not expecting to make them pre-hospital physicians, but we want them to be a bit more comfortable in that space if they have to move those patients. A large part of the curriculum focused on system and operations and speaking about the importance of integration. And that comes to simulation-based cross-training kind of things between cross-professions. And then lastly, something that we don't do quite well in a setting which is resource constrained is our crew resource management, because we often don't pay a lot of attention to that. It's just go out and do the next call. And EMS somehow, and I think it's across the board, is also semi-hierarchical. So we don't, it's probably what you see on the ED floor as well, but we often don't feel comfortable to speak up to the next practitioner. That's something we try and train to say that we're all equal. Doesn't always work that well. And then again, it comes to leadership and a lot of mental health and wellness things which we kind of leave untouched. We do have hot and cold debriefs. It's also been spoken about earlier on, but it doesn't always happen. It doesn't always play out as it should. And then that's basically it in a nutshell. Then the kind of what I said earlier on, it's not just about the clinical medicine anymore. So we would like to have a practitioner that's kind of be able to do advanced decision making outside of the general kind of protocol thinking, because the patients in the ICU space doesn't fit those that we get trained for. Also, someone that's actually part and parcel of the planning and the coordination of the transfer, because currently it doesn't work out like that. We've got the referring facility going to dispatch and control center, where up until the last 2 years, there was no one with medical backing in that space. So it was really a kind of, we choose where we want you to go. Still till today, the clinician that actually goes and services the call is not so much part in the planning phase of it. And if we face, for those of you that's familiar with South Africa in the Garden Route area, really pretty side of the Western Cape, a transfer from our George Regional Hospital to Cape Town Groote Schuur Hospital will take us up to 6 hours. So I mean, that will need to have some sort of significant planning going into that. What equipment do we need in that? Notebook LM messed up this. This is not my words. But again, when it comes to ventilation and monitoring, I think this is probably quite pertinent because some of the data came out of COVID. But we are generally quite well trained with the normal things, lung protective, restrictive, obstructive, but when it becomes really challenging, we run out of our own depth. We don't know what to do. So there's a little bit more that we need to do in that space. And then I think it's just something where we can actually tie in our referral networks. We have some of them. A lot of them is relational based. So if Louis is working today, it's easy to speak to the next facility. If I'm not there, it might not be the reality. And then the lastly is just a quote. So why do we think it's relevant in our space, not just in the Western Cape, but in South Africa? It's not going to fix the resource constraints, but at least it will be able to kind of merge that divide when it comes to the level of care that we provide between the city and the metropole space. Something that's not done well in South Africa, but the rest of Africa is doing it quite well, is also allowing for a little bit of task shifting. And if I'm saying this is, say, I'm a diploma paramedic, for example, with a 3-year qualification, but I'm working in a very rural space, and we do see the need to move a lot of patients that's intubated and ventilated. Maybe we need to upskill those individuals in that space and give them a regional kind of expansion on scope. When we don't do that quite well. We don't do it at all, but we are looking at it. And then ultimately, if we have a standard kind of approach to our training, we should be able to reduce the amount of adverse events. Again, this is also not very well reported outside of our province, which is a concern. Kind of practical takeaways, I think it is important for us, regardless of where we are, to avoid a copy and paste kind of model, develop something that is contextual. I'm also not saying don't look at what's been done elsewhere. It can give you great ideas. But in our space, we need to have something that is kind of able to function within in the resource-constrained environment and with our current disease burdens. Focus on system integration. Clinical skills only goes thus far, but if we don't have the logistics sorted out and we don't have our providers actually speaking to each other, we don't have the silos broken down, which I think is quite pertinent in emergency medicine in general, we lose out somewhere. And then again, we can implement this incrementally. This curriculum thing has been developed over the last couple of years. But my own service as a critical care service, many of the other provinces have some sort of something in the private sectors, all with in-house training programs. There's no official credentialization that happened, but we kind of went the path already to get to the point. The last 2 slides, this orange is probably not that important for the audience. That's our own regulations, our own problems, which we can't fix. But again, we'll need our health regulator to kind of approve something like this to lead to a point of specialization. Actually have our ambulance service have enough funding to afford these individuals, because they're not going to go and do the qualification and come back if they're not remunerated appropriately. But the top part is kind of what we've done. We have now came up with a full curriculum. We've got endorsement from majority of the universities in the space. And the next step will be to focus on the kind of orange dots, which is a little bit more challenging. And then I think it's also just to do the ongoing research in our space to see if what we're doing is actually working. This is a little bit of a repetition of the previous slide, but again, it's the development of a evidence-informed curriculum. Critical care retrieval is a systems challenge. It's not just a clinical skill set issue. And then the curriculum alone won't save lives. It will also take the regulatory part to be solved. Then critical care retrieval is not just a gap in the system. It's our greatest opportunity to elevate pre-hospital care and guarantee equity of access in our space specifically. Thank you. That's it. Sure. And hopefully there's not a lot of questions. If you want to see some of the work that we do in our space, you can scan the QR. It will take you to my research gate. You don't have to follow me, but there's a lot of things going on there, which is quite interesting. Yeah, thanks.
Excellent. Thanks so much, Louis. And yeah, always really interesting to get some insights what's going on. So let's hear it again. We are running a little bit behind, but I'll dob Louis in and say, feel free to come up here, have a chat to him if you do have any questions. Let's grab a quick break. Try and be down in maybe like 10 minutes. As a heads up, we probably will run a little bit over today, but that's better than trying to rush people through. So grab an extra big plate of food and don't be late because you may be winning an iPad. So that's the little tease to get you guys back in here. Thank you, everybody, for making it back in the room. It is time for our final photo competition prize bonanza of the day. Do we need to do a practice cheer? Big cheer. What do we have to do? There we go. We know what to do. Lots of shirts, passport wallets, so don't be shy when calling out your favourite. I think, once again, around about 10-ish photos. So let's get it moving. Oh, the boys at the beer station. Not bad. Is that the craft beer place, I think? Oh. It's a really good photo. Oh, God. Can confirm Mel's still here. That's good. Oh, that's a nice one. Yeah. So happy, love it. All right, I reckon that's a winner so far. Oh, look at that. You can't get another t-shirt, but you can get a passport wallet. Oh, that's very talented. Oh, now we're talking. Ah. Oh, the coconut boat. Oh, that's Eb on his scooter. Nice one, Eb. Oh, we're supermodel scarecrow of Hoi An. I like that. That's going to get a prize. Oh, and our favourite, Scarlett. Oh, Scarlett's already got the prizes, so that we can give whoever gave that photo, they can get a prize as well. So, spotting Scarlett, a bit of a superstar. The lantern making, the group doing the beer, and I think I mentioned the other two, didn't I? Yep. Where's Wally? Yep, we happy with that? Yeah, perfect. As you can see, very scientific approach, that one. We actually looked at getting there's a thing you can download on the computer that measures the noise of the audience and stuff like that. It would mean less complaints, but we thought we'd do it that way. So Delphine has sent me through who the winner was. Let me just pull it up. It's like the Oscars, isn't it? Hopefully it's not the wrong envelope situation. Delphine. All right. So, big thanks to Delphine and Max for all their help this week, actually. You can come up on stage, that's okay. Let's hear it for Delphine and Max. So Delphine and Max are our good friends from Bali, originally from France, hence the accent, and they are here representing Locum Life as well, and have very kindly donated this iPad to our lucky winner, Simon Haywood. Simon, are you in the audience? Simon's not in the room. No, we can't do a redraw. Looks like Dylan's the lucky winner. Newman? Simon Newman? Oh, he is in the room. Oh, big round of applause for Simon. What I said, Simon. Whoops. There we go. Well done, Simon. Enjoy the iPad. Yep, there we go. There we go.
Thanks very much.
Brilliant. Thank you. Congratulations. It was almost the wrong envelope situation, just me getting the surname wrong, so there we go. Last two presentations. So really great to have Erin, who's actually a couple of months ago got the call up because we had Vivian King, who's presented a few times before us in the past from Victoria, and she's done a lot with setting up the virtual ED that Erin's going to talk about. And word is she's been seconded to another role, or she's somewhere else and wasn't able to make it. And she said, hey, I've got someone else awesome to come and present. So thank you very much, Erin, for stepping in. It's great to have you here. Let's hear it for Erin.
All right. So what do? Do I just
Beautiful. Okay. So last week, around 800 Victorians had what they believed was an emergency, and most were safely managed without ever setting foot in an emergency department, with nurses like me central to that care. Hey everyone, I'm Erin, and I'll be speaking to you today about nursing in the Victorian Virtual Emergency Department. I've been nursing for over 10 years, primarily in emergency departments, before starting in telephone triage after I became a mother, as it helped me step away from the chaos of the ED, but I could still use my skills. I joined VVED just over 2 years ago, initially as a triage nurse, then as a clinical nurse specialist, and now I'm part of the ANUM group. It's given me a really unique perspective, and it's something I'm really passionate about. It's one of the few roles where emergency nursing and telephone triage genuinely intersect. And essentially, this is what this model relies on. I've been through the service through a period of fairly rapid growth. When I started with VVED, we were seeing around 550 to 650 patients a day. Now we're seeing an average of around 850 patients daily. Today I'll walk you through how VVED works, but more importantly, what nursing actually looks like inside a virtual emergency department and what we've learned as we've grown. At its core, the Victorian Virtual Emergency Department is a free statewide emergency service delivered entirely via video, operating 24 hours, 7 days a week. Patients can access us through services like Ambulance Victoria, residential aged care facilities, and they can also access us via services like Nurse on Call, Health Direct in other states, or directly register online, as long as they're currently in Victoria or its border towns, and they have a video-compatible device and internet access. Every patient is assessed over video by an experienced registered nurse, and also often a doctor or a nurse practitioner with real-time clinical assessment and decision-making. We're currently seeing an average of 850 patients a day and have now managed over 850,000 presentations as of March 2026. What makes the model different is that we sit in front and to the side of the emergency department. We aim to safely manage patients at home where appropriate and reduce avoidable ED presentations. So our most common presentations include respiratory issues, shortness of breath, 37 a day, nausea, vomiting and diarrhoea, around 26 cases a day, and then fevers, which accounts for around 22 cases a day. Then if we look at our age demographics, you can see roughly 40% are working age adults, 32 paediatric presentations, and 28% older adults aged over 65. And what this tells us is this is genuinely a whole of population service. We're not just seeing one demographic, we're seeing all of Victoria. And so while the environment is different, the responsibility isn't. This is still emergency care, just delivered in a different way. To understand how the service works now, it helps to understand how it's evolved. VVED started in 2020 as a small pilot operating limited hours with only one nurse on shift. Over the past 6 years, the service and the role of nursing within it has evolved significantly. In 2021, we partnered with Ambulance Victoria. 2022 saw us become a statewide service. In 2023, we commenced a partnership with Nurse on Call, and then 2024 saw the endorsement of our own triage tool, and we went live with our own registration platform. In March last year, we hit the milestone of 500,000 patients seen, with approximately 40% of these patients triaged by nurses. By Easter, or around the next 6 months, we expect to have reached 1 million patients seen. So as the service has scaled, nursing just didn't grow in numbers. The roles themselves evolved to manage increasing complexity, risk and demand. And as the service has expanded, so have the pathways that patients can access it. So there's two main pathways. The first is healthcare practitioner referrals, so from Ambulance Victoria, aged care facilities, and other healthcare professionals like GPs or emergency departments. These patients already have a clinician with them and are streamlined directly to a doctor or a nurse practitioner, which includes specialists in general emergency care, paediatrics, diabetes and geriatrics. Our nurse practitioners have played a significant role in expanding our service, particularly overnight, and in specialties such as palliative care and diabetes management. The second pathway is where patients access the services themselves from home, either via self-registration or through pathways like Nurse on Call and the Maternal Child Health Line. These patients are triaged by our nursing team, and this is a pathway I'll focus on today. At its core, nursing in VVED is about risk, decision and flow. These functions sit across 4 domains: the clinical delivery, real-time clinical support, operational oversight, as well as quality, safety and clinical governance. These 4 domains are where nursing doesn't just contribute, it holds the system together. So at the core of our model are our triage nurses. Our registered nurses are all very experienced, have a minimum of 4 years post-registration experience within ED, ICU or in another acute setting. They assess all patients using an ADE approach, adapted to the virtual environment and allocate a category using our Virtual Assessment Triage Scale, or as we call it, VATS. Their work is supported by other specialised tools which have been developed, including our mental health decision-making support tool, our own trauma guidelines, and a AAA flowchart which has been adapted to the virtual world. Our nurses also support our patients by completing periodic reassessments of those patients waiting to be seen by a doctor or nurse practitioner, helping them locate appropriate health services, and directing them to reputable health information, as well as calling 000 and requesting an ambulance for them. These are real, high-stakes clinical decisions that determine whether the patient stays at home, escalates within the within VVED, or is transferred to other emergency care. To support this, we have a layer of real-time clinical support. This includes clinical support nurses and clinical nurse educators who facilitate the the training and orientation of new staff. They offer on-shift clinical advice and run regular in-services. And we've also recently started doing in-person study days on scene. That initial clinical support during shifts is very important in a remote workforce because you don't have that same informal support where you can go and just tap someone on the shoulder like you would in the ED. Okay. So, VVED started with just a handful of nurses, then gained more nurses, and then a nurse unit manager, and then associate nurse unit managers, and still continues to grow today. To run a 24-hour service, our nursing leadership now operates across 3 levels. So we have a Director of Nursing, David Wright, and he connects us to the executive leadership team. Ella Tunbridge is our NUM, and her focus is on workforce and performance. And then Chloe Gay is our clinical nurse unit manager, and her focus is on guideline development and day-to-day operational concerns. And then the ANUMs, pictured here are Teresa, Cami and Tamara, which is also my role. We manage the shift in real time. We have 2 ANUMs per shift. We coordinate patient flow, staffing management, troubleshoot issues, and offer backup clinical support for the triage nurses. So nursing huddles run 6 times in a 24-hour period, and medical huddles are run 11 times. And these are all run by the ANUMs, which is even more important in the virtual space. So while these guys are focused on the bigger picture, we're focusing on what's happening right now. In many ways, we operate as the shift coordinator of the virtual ED. So as the service has grown, we've had the need for a dedicated quality and safety leadership. So this is Viv, who Quint mentioned earlier. She was our quality and safety ANUM, but has now been given the role of quality coordinator for the whole virtual health division. So if you're lucky enough to be attending the Bali conference in October, you'll get to hear from her. So her role in VBED focuses on incident review, data analysis, as well as improvement, implementation and evaluation. So in a model that's constantly evolving, this work is essential to maintaining safety and consistency. So as a relatively new and evolving service with a large number of quality improvement projects that have either recently been completed or are currently in progress. The best way to show you how nursing actually shapes the system is to show you what we've changed. I'll briefly step through a couple of examples of nurse-led projects that have had a measurable impact on the service. Firstly, one of our challenges was call abandonment, so we set out to change it. Secondly, we had feedback that perhaps not everyone referred to the ED needed to be seen in ED. So as part of that, we implemented our own priority triage category. Sorry about the decimal points. So one of our early challenges was call abandonment, with rates rising as high as 27%. So in response, nursing led a redesign based on call centre best practice and introduced a structured 2-call follow-up process. And the results were significant. Within weeks, rates dropped down to from 11.79 down to 2.21. The 2-call process has remained embedded in our workflow ever since. And our current did not wait rate sits around 3 to 4%, even as we've reached those larger numbers coming through our department. So a process that was designed in 2022 is still working for us in 2026. So that's what embedded nurse-led change looks like in VBED. We've also added additional safety netting for high acuity patients, as well as following up with next of kin or police welfare checks where it's necessary. But we're not stopping and maintaining this fix. The next evolution is to hopefully remove the need for follow-up calls altogether, and we're going to try and have a call-in system where we are calling patients in rather than having them sitting there waiting. So no queue, no missed calls. So we're not just solving the problem, we're redesigning the system so the problem doesn't exist. The second example relates to our Category 2 patients in our initial triage scale, identified as requiring urgent assessment. So the initial triage scale had 4 categories, which were ED via ambulance, ED by a private car, review by a clinician within VVED, or referred to a community service like a GP, priority primary care clinic, urgent care clinic, or pharmacy. Feedback from emergency departments suggested that perhaps not all these patients that were given a Category 1 or Category 2 required a medical physical intervention. So we reviewed the data and identified that a proportion of these patients could potentially be managed safely within the VBED model. In response to feedback from the EDs and reviewing the data, we updated the triage model, which is now ED via AV or private car, and this is a new category introduced, a VVED priority review, and the other 2 categories remain the same. So Category 2 patients are now escalated for priority review by a doctor or nurse practitioner, usually within 10 minutes of being assessed by the nurse. This allowed assessment and early intervention of care before a final disposition decisions being made. So in the initial evaluation, approximately 55% of these patients were safely managed within VVED rather than being sent to ED. So it allowed to shift from a blanket referral model to a more nuanced clinician-led approach without safety being compromised. And the broader picture backs this up. So if you look at our diversion rate, the proportion of patients who've managed to be managed without going to ED at all, we've constantly sustained above 80%. So even in our busiest periods, we held at 81. That's about 4 in 5 people being managed within VVED without having to go to ED. So this project ultimately contributed to VATS, our own triage system, being implemented. And it's something that constantly undergoes review, and it doesn't just improve individual patient outcomes, but it changes how the whole system operates. So we still have some more ongoing and in progress projects. So audits and case reviews, which I've got that one, I wear that hat sometimes. The thunderstorm asthma plan, so we're developing a code brown response for Victoria in dealing with any thunderstorm asthma. Improved sepsis recognition, so our clinical nurse educators are working really hard on improving the support the nurses have in their assessments for sepsis recognition. We're also working on virtual specific clinical practice guidelines. And another thing I'm working on is we have an interpreter process set up, but sometimes you can't get an interpreter. So how do we manage those situations when you can't get an official interpreter? So these programs, they ensure that we continue to grow and we don't just get bigger, but we get more safe as we get bigger. So another quality improvement project model that's currently undergoing redevelopment within the VVED is the virtual liaison nurse model. There we go. Sorry, guys. So it involves VVED nurses that are actually working within the Northern ED. They will review appropriate patients and refer them into a booth within the physical ED for one of the virtual clinicians to review. So it's still being evaluated, but if it's successful, it has the potential to be expanded across other emergency departments. This flips the model. Instead of bringing patients to VVED, we're bringing VVED into the ED. So like any new model of care, there are going to be ongoing challenges. As a team, we actively encourage our staff to give feedback, which is reviewed and actioned by our quality leads. And this feedback often helps us overcome challenges and leads to improvements. Workforce is a key one, particularly maintaining skills, engagement, and clinical support in a remote environment. Technology is another. The model relies heavily on digital platforms, so we need to be reliable and fit for purpose. This is something that continues to grow and evolve in VVED. But finally, team culture. So building and maintaining that virtual workforce requires deliberate effort. It doesn't just happen the way it can happen in a physical ED. So we asked the nursing team how they maintain connection and support in this environment, and this is what they had to say. You can see a consistent theme: communication, proactive support, and staying connected. From a workforce perspective, this includes structured roles, education, and real-time support. From a wellbeing perspective, initiatives include newsletters, social events, and psychological first aid training. Some of these challenges are unique to virtual care, but some are not, but all of them require deliberate system design. So the VVED model is continuing to evolve. there's a growing opportunity for nurses to actively manage defined patient groups within the department, like our new virtual observation ward. That model is still evolving, and with new leadership in place, a lot of work is just beginning to take shape. There's also a strong focus on redefining governance, education, and system design as the service matures. Virtual emergency care is no longer a temporary solution, it's an established part of the healthcare system. We also asked our nursing team where they see VVED heading. What comes through really clearly is growth, opportunity, and the expanding role of nursing within the system. It's not a pilot anymore, it is a system. Can virtually take us anywhere. So to bring it all together, virtual nursing in VVED is real emergency care. It's real clinical assessment, real decision making, and real risk management. It's real emergency care. It shapes the system through quality improvement, through nurse-led design, and through roles that hold the service together. And it's continually evolving. As a service grows, nursing grows with it. Thank you.
Thank you, Erin. That was great. Any questions? Got time for one. Who's got the best question? Oh, you're brave, giving your hand up. Here we go.
Hello, I work in WAVE, so WA Virtual ED. It's we're in the infancy stage, I guess. But I have a few, but you said just one. I'll make it quick. So, what is your representation rate within 24 to 72 hours post-discharge from virtual service? The other question was, what's your work from home ratio with staffing? Like how many staff are inside and how many staff are work from home?
Yep.
And the last one was very relevant still. What's the role of AI triage or any AI innovation within this space?
Okay, so answer to your first question, I don't have that data, but I absolutely can get it and send it through to you at another stage. I guess I could probably just speak from what I see. We don't get a lot of representations. We obviously do. You still have some representation rates. But, I mean, as you get your frequent flyers or people that have frequent presenter plans. So we do have those sort of people within our department. But, yeah, I can't give you an exact number about representations. Our workforce, I would say 95% are working from home. So VVED started out of the Northern Hospital in Epping, so that is still our main epicentre. There is the ability to work on site there, but when I've got 12 nurses on a shift, there are not 12 pods in there, so people have to work from home for the department to work. So, and what was your last question?
AI.
Oh no, so nursing is not using any AI at the moment. There's nothing that we're doing with AI. I know from a medical perspective, obviously a lot of medical clinicians use it for their dictation, their notes, and I know that there's been some discussion from leadership about that, so it's still a very open area. I don't think we've got no strict rules or conditions around it, but it's obviously something to look into, can it help us, and can it help people in a good way, I guess is what we'd be looking at.
Consider it for language interpretation as well as managing your upfront call volume. So those losing calls because of that, consider using that as a pathway.
So we're just getting a new telephone system coming in, like a call centre based system, which is, I believe, will enable some of those AI things. But again, it's going to be looking across to make sure that we can maintain our safety and our quality if we use them. So cool. If you do want to talk to me, ask me a question, you've got anything, you can scan this little QR code and it'll give you my business card. So if you did have questions and we didn't have time for me to answer them, feel free to email them. Happy to help where I can. Thanks, guys.
Thank you, Erin. Now, just before we start the next presentation, I hear it's someone's birthday today. They dobbed themselves in. Mary, it's your birthday. Let's sing happy birthday to Mary. All right, who's going to start us off? There you go. We got to embarrass you instead. So happy birthday, and apologies if it was anyone else's birthday this week. We can always sing again this afternoon up at the rooftop. Final presentation. Sorry, I'm just going to bring up the right one here for David. I think this is David's third time presenting for us. It's always brilliant to have him on board. He has an amazing background and really sort of unique perspective he's able to bring to our conferences. So thank you for joining us once again, David. We love having you here. So let's make David feel nice and welcome as our final presenter.
Hello, can everyone hear me? Yeah, good. So as Quinton said, this is my third time I'm presenting at EMS. So I'm both persistent, recurrent, and in that way I'm a little bit like genital herpes. So we'll see if I'm as painful over the next half an hour. All right? So we're here to talk about negotiation, which I think is a key skill in clinical practice. So this talk goes for about half an hour. I appreciate that if any of you have tours booked or places to be, please feel free to stay as long as you want, and no offence taken if you just need to disappear. So standard boilerplate disclosures, nothing really to disclose here other than to say that I feel like I'm sponsored by the Australian Taxation Office because I'll be aggressively tax deducting my holiday in Vietnam, and I encourage you all to do the same. Thanks, lads. So who am I to talk about negotiation in clinical practice? So I'm an old dog. I've been doing emergency medicine for over 25 years. So I'm a face of emergency physician in Canberra, Australia. So I can no longer rely on youth and exuberance. So I now have to rely on old age and treachery to get things done in my hospital. I've spent a long time in clinical medicine. I'm primarily a clinician. I enjoy seeing patients. I have had some experience in educational and administrative roles in emergency medicine, which I've enjoyed a lot. About 10 years ago, I felt that the world needed another lawyer, so I retrained in that and hold a practicing certificate and do medico-legal work with a major medical defence organisation in Australia. And I've been doing that for the last 5 years. And that's given me a really interesting perspective on why things don't necessarily go according to plan in clinical practice. So part of my work in that organisation involves looking at civil claims, so when doctors get sued, professional conduct matters, when complaints are made to regulators such as APRA or various sort of state-based complaints entities, and I also do a little bit of work assisting in employment disputes. So part of legal training is a little bit of work on alternative dispute resolution, because it is very expensive to go to court. So there's a big move in the legal world to use litigated processes as a matter of last resort. So there is a lot of dispute resolution events such as mediation and other processes, and particularly negotiation. And as part of my role with a medical defence organisation, I've had the privilege of seeing some of Australia's best personal injury barristers go at each other at mediation and dispute resolution events. So this talk is really just my experience. I want to assure Anand that no p-values or decimal points were harmed in the writing of this talk. It's really just a fireside chat. So to set the scene, I propose that you are all negotiators in the work that you do. And I've got 3 cases to illustrate that point. Because disagreement and potentially conflict is everywhere in our healthcare and hospital systems. So just to paraphrase the slide, imagine you're a senior emergency physician, you're seeing a child who's probably got gastroenteritis, you wish to admit them to the ward because you feel that that will be in the patient's best interest. There's some social issues that are sort of happening alongside all of this, and overall you feel that the patient should be admitted under a paediatrician for intravenous fluid rehydration. And the paediatric registrar, who's very polite and very correct, reminds you that you're currently in the middle of a very busy flu season and there's in fact very few beds on the ward in the hospital. So this is one scenario. Scenario number 2. Imagine you're an experienced paramedic and you're seeing an elderly patient who's rung your service with chest pain. You recommend transport to hospital, but the patient who's elderly says, look, they feel their chest pain's now resolved, and they point out that there's no one at home to look after their small dog, so they're not going to hospital. Case 3. Imagine you're an experienced registered nurse and you're doing shift work. And I must say, shift work is both the best and the worst part of our jobs, isn't it? All right? So imagine that you've been rostered to do some night shifts, that's part of shift work, but you feel that for whatever reason you're doing more night shifts than what is reasonable and what you can manage, and you need to discuss this with your roster manager. By the way, a little bit of a shout out to anyone in this room that writes rosters. I had my first experience of writing rosters when I was a 24-year-old PGY2 because the director refused to write the emergency department roster. So I wrote the whole medical roster for the department at the age of 24, and that has shaped my views on how difficult writing rosters are. So a big shout out to you. But the process of writing rosters and being rostered is potentially one of negotiation. All right, now I'm definitely not a psychologist, but in writing this talk, I wanted to think about what are the universal attributes of human beings. And I'd like to propose that in the context of negotiation, we all need some element of control in the tasks that we perform. Does anyone disagree with that? Great. All right, so that probably 150 people in this room. And we all need to feel listened to and have our views considered. Anyone disagree? Good. All right, so 100% agree. Still waiting for the American Statistical Society to put out a position statement, but we're in fairly good agreement there. And so that is important in the context of negotiation, because the old adage of treat people like you want to be treated, I think can be very true. I'd also like to think that we have this keen sense of fairness that is potentially innate about how others are doing, and we're pretty good at pointing out if we're not getting a good deal. Right, I'll give you 2 examples. The first, so imagine you're on your way to your next EMS conference, all right? You've secured your leave, you've got a good deal on your airfare, good deal on accommodation. You get aboard the aeroplane, flight looks potentially a little bit full, you're jammed in the middle seat for the next 8 hours. But life's good, you're going to an EMS conference. Imagine the last passenger to board the plane is seated in an empty row of 4. They're a little bit rude to the airline staff that are settling them in. As soon as the seatbelt sign goes off, they stretch out across an empty row of 4, and you're watching this for your entire 8 hours jammed in the middle row, right? Nothing about that person's good luck and good fortune has reduced your good luck and good fortune in going to EMS conference. we just have this innate sense of fairness. And it's innate because I'd just like to describe an example involving my own children. Like any responsible parents, I buy my children ice cream. Occasionally, they get a double scoop when I think they've deserved it. So to incentivise a long bushwalk, think, 20 kilometres in 40-degree heat, I think they can have a double scoop, right? Because a single scoop's my usual default. And my son, who's 9, he cannot eat a double scoop, right? I'm forever tipping out the half a scoop of ice cream into the bin that he doesn't eat. Imagine the hell to pay for me if after doing the same bushwalk, I bought him a double scoop and his 2 sisters a triple scoop, right? He's still got a good deal. He's actually getting more ice cream than he can eat. And, he's getting a double scoop, right? Like the guy's walked 20 k's, 40-degree heat. He deserves a double scoop. But someone else is getting a triple scoop, right? So it's a little bit innate in terms of fairness. I'd like to also propose to you that we don't like to lose as healthcare professionals. And you guys, by virtue of sitting in this room, are winning in life. Now, true, you've got to listen to me for the next 20 minutes, but you are all winning at life. So you're on holidays, you're in a beautiful destination in Vietnam, you're getting half back from your holiday from the ATO, and to get to this point, you all have had, studied at university generally, and you're all employed, right? So you're winning at life. And you have had far more wins to get to the position you're in than you have had losses, all right? So when we negotiate with our colleagues, we have to be aware no one likes to lose. Everyone wants to feel they got a good deal, right? The other thing I'd like to contend is that no one will ever completely capitulate. So no one's ever going to completely fall apart and confess that they're wrong. So, an example. As I'd mentioned, I've got 2 teenage daughters. They need some encouragement to put the bins out, right? And any parents of teenage daughters would, this story will resonate, right? So they'll sit on the lounge, on their phone, on the Insta. I'll remind them to put the bins out. They'll ignore me. 5 minutes will go past, I'll ask them again. Right? 5 more minutes will go past, I get a grunt. I'm lucky if they groan and moan, grab the garbage by the scruff of the neck, flip me the bird and take the garbage out, right? That's totally a win, right? Like, that is a win if you're a parent, right? What really should happen is that my daughters should acknowledge that being a father is a difficult job, that I'm trying my best, that in fact they were completely wrong in treating me the way that they were, and that they'll apologise and they'll take the bins out without being asked the next 2 weeks, right? That is actually a fair outcome in that scenario. But to expect that my daughters are going to entirely capitulate to that position, that's just fanciful. So when we negotiate in clinical practice, sometimes the outcome that we think we should get, which is an apology, an admission that the other person is not behaving well or has made the wrong decision, is an outcome we're probably never going to get. Right. Now, a slide on specific attributes of people. So for anyone that's done a small bit of business training, think workshops with a bowl of Mentos, an over-enthusiastic presenter, and a bit of blue sky thinking with some butcher's paper, right? The concept of DISC personality comes up. So this is sort of a little bit pseudo-scientific. There's not just one tool, but it's very much crept into business studies and the way that we can view human beings, and is the basis of Thomas Erickson's book, Surrounded by Idiots. So you may wish to refer to that. So the premise goes that there's a spectrum of people, from those that are task-orientated on one end to people-orientated on the other. This is the horizontal. And then there is also a spectrum of people that are reserved, introvert at the bottom, up to sort of outgoing, extrovert at the top. And then you can divide people into 4 categories, right? Now, everyone can sort of flip-flop around the various categories, but most of us seem to have a happy space. So there's on the red group, and the colours vary a little bit in terms of which sort of model you're sort of looking at, but the first group is a sort of a dominance group, so they're very outgoing and very task-orientated, right? For those of you that are Star Wars fans, this would be your Darth Vader, right? Then there is a influencing group, so those people that are persuasive and enthusiastic, and they're very people-orientated. So getting outcomes that assist people is what they're interested in. They're not so much interested in just getting the job done. So the Star Wars analogy continues. That would be a sort of Princess Leia, right? Down the bottom, you've got a very reserved, people-orientated individual, and they're just great listeners, right? So your Chewbaccas. Chewbacca's a great listener, right? And then your Cs. So these people love data, right? They're very reserved. Think your local accountant, right? But to continue the Star Wars analogy, think Obi-Wan Kenobi, right? So this is one way of thinking about how you may wish to negotiate with someone that you know. Now, not all the time in healthcare we know people to this degree, but the point is, if the person you're negotiating with is very data-focused and is going to take some time to think about the outcome, that is classically your Cs, so you might want to give them the data, right? With D, they don't need a lot of data. They're very results-orientated. You might want to think about how you can give them a solution where they think they've actually come up with it, right? So most of us in healthcare are probably sort of Ds and Cs, right? That's where we fit, particularly in emergency healthcare, right? We see very difficult decisions. We need to make very quick clinical decisions based on minimal information, right? So I'd argue that most of us are sort of Ds and Cs. This may or may not be helpful, but it's just an observation about how you might want to think about the person that you're negotiating with. Now, I think I'm going to get some nods of agreement with this next slide. When we negotiate in healthcare, particularly in emergency medical practice, it is very different from the business world. It is very different from negotiating a legal dispute. And I've put up a couple of my thought bubbles as to why that is the case. It's high stakes what we do, and we sometimes deal with people having to deal with very difficult problems and people that can become very emotional. Our work is time pressured. There can be multiple solutions to the problem, but there may not be. And importantly, unlike business, once you get close to an agreement, you can never actually split the difference. Right? So if you're arguing with an inpatient registrar to get a patient admitted, you can't just say, oh, look, can you just admit this one and the next one? Look, I'll just deal with, don't worry about it. I'm going to tell you that I'm not going to ring you. Like, you cannot split the difference. And unfortunately, in the hospital system, there's not a huge incentive, particularly in big organisations, to really value the relationships. I had a very sobering experience a couple of years ago when my son, and he's the one that can only eat a scoop and a half of ice cream, was admitted on several occasions with a viral-induced wheeze. He was in the paediatric HDU. He was a bit sick, but I figured he was always going to be fine. And the medical teams would come around and I would say to them, hi, I'm David, I'm John's dad. And this was in the tertiary hospital. Now my practice is at the non-tertiary hospital in Canberra. And they said to me, almost without fail, yes, Dr. Banfield, I know who you are. Because a lot of them had been my resident when they had been rotating through the hospital where I'd worked. And I had forgotten who they were. They had not forgotten who I was. So it was a very sobering experience that the relationships you develop at work are important. This would not be a talk on negotiation without mentioning, I guess, the landmark publication of the book Getting to Yes. So this was written in the early 80s by the Harvard Negotiation Project, and this has transformed how negotiation theory works, at least in the sort of developed Americanised world. And this is the concept of principled negotiation. And Marianne in her talk touched upon this on the first day, which was the Tuesday. And this is talking about interests and talking about positions. And I'll get to the next slide where I define that a little bit more. Another key principle is separating the people from the problem, right? That's not to say that we disregard the people. What it is to say is that we need to play the ball, not the man, right? So that we're hard on the problem, soft on the people, right? That's what that means. We need to think about opportunities to invent mutual gain, and this is this concept of sort of increasing the pie to be divided. We should insist on using objective criteria. So one example in healthcare could be hospital policy. And when you negotiate, you need to know your BATNA. So your BATNA is the best alternative to negotiated agreement. So that is what you are going to do if you can't negotiate an outcome, right? And your BATNA determines, I guess, the strength of your position, how keen you are to get a negotiation. So just as an example to define interests and positions, and this is sort of oft used. And I guess the sort of overly simplistic example is perhaps an inherent weakness of the model, because it probably describes how the world should be rather than what the world is actually like. But imagine there's an orange. So there's a single orange on the counter in your home. And you and a housemate, husband, wife, boyfriend, girlfriend also wants the orange. So the position of each of you is that you want the orange. And someone invariably asks, well, can we have half the orange and split that? And the answer comes back from both of you is that no, half the orange won't do, and in fact that's the only thing you agree on, that you need the whole orange. Now, interests are what sort of, I guess, defines the position, and interests are how you get to that position. So imagine you want the orange because you want to make a glass of orange juice, right? So you're going to squeeze the orange. Imagine the other person wants the orange because they want to use the zest to make an orange cake, right? So sickly sweet example, but it sort of tells us that we need to go a little bit behind the position and figure out what's driving people. Marianne in her talk gave a beautiful example of this. So if you recall, she was speaking with a registrar who would not allow a dying patient to be admitted to the ward. So the position from the registrar is don't transfer that patient to the ward. When she asked about the interest was I don't want to be criticised if that patient dies en route to the ward because that's what's happened last week. So in asking that interest, that enabled a better conversation around trying to get to a reasonable outcome. So I thought I'd develop a few rules. Again, we're continuing the fireside chat. Nothing is set in stone in negotiation. I don't have any academic literature to back it up, and in fact there's not much literature in the healthcare world about negotiation, unlike the business and legal world. But I thought I'd develop a couple of rules. So you've got to ask yourself the question, who is it that you need to convince? And in the context of healthcare, that can actually be really hard to identify who is the decision maker. Sometimes for patients, that can be family members and other supports. And so you can in fact engage those family members and other supports to assist the patient in arriving at what you think is a reasonable decision. Now, the caveat of that is you need to do that ethically. Everyone has their own autonomy to make their own decisions. But sometimes engaging family members when speaking with patients, or at least sort of ensuring family members are in the room when you give your recommendations, is actually probably good practice. You know, who is it that has the final say on whether a patient's admitted to the ward under the inpatient team? It's generally not the registrar. So on some occasions, you might need to pick up the phone and speak to whoever that admitting physician or surgeon is. And definitely don't take a no from someone who can't give you a yes. And you would have heard of that before. So do know the system you work in and the personalities. And know who, in fact, is the decision maker. So my experience, the number one reason why negotiations fall apart in healthcare and lead to exchanges of sort of heated emails to unit directors about people's behaviour is when people just lose it. So when you negotiate, you'll try and be as calm as you can. And yes, the situation may be stressful. I sometimes, when I know I'm going into a difficult conversation, be that with a patient or a colleague, I just have a 20-second break, right? And I just brace myself for what's to come. And I try not to enter into negotiations when something else is causing me stress. If you're not calm, then the other party spends all of the time that they should be spending in negotiation, and in fact all of their bandwidth, in defending themselves from you. And both of you then quickly lose the ability to focus on the issues at hand. And I guess this is what is meant by separating the people from the problem. I'd already touched on this, take your time when you can. We work in busy environments, but some of our time pressures are potentially a little bit artificial. And it's much quicker to spend some time getting a good negotiated outcome than often what it can be implementing your BATNA, right? So that's why you've got to know what your BATNA is. Think about what you're going to do if the negotiation fails, and if it's really critical that you negotiate an outcome because your BATNA is pretty weak, take the time, engage in the negotiation, remain calm. Now, that's not to say, I guess as a disclaimer when addressing an audience in emergency medicine, graded assertiveness is entirely appropriate where there's a clinical emergency. All right, what I'm saying is in the context where there is not an emergency, take your time because that can be more efficient in the long run. My next point is about listening. So just listen. Try to not dominate the conversation. Understand the clinical reasoning and ask for the clinical reasoning. And this has a patient safety element because we're not right 100% of the time. And certainly I have gone into negotiations on patient outcomes and disposition, and new information has been presented to me, or a new way of viewing the problem has been presented to me, and by listening that's caused me to change my mind on what I think the optimum outcome is going to be. So do stop, listen, and this very definitely has a patient safety element. Again, try not to dominate and outflank your patient. Some of us, as I said, in healthcare, because we're used to winning at life, do sometimes have a tendency to want to be the smartest person in the room. I know I've got colleagues that do that. And so if you're constantly trying to outflank an opponent, they will just need to defend themselves and they will very quickly become unfocused on the issue at hand. Definitely don't snip back at every sentence, right? That derails the conversation. Listen to what someone's saying, consider it, and then provide a rebuttal or provide your position. So I've got friends and colleagues that are barristers. Rarely life is like Law and Order, where the witness is on the stand and they're completely outflanked by the barrister with one or two questions to the point of pleading guilty and needed to be dragged away by the bailiff. That does not happen in court, and it does not happen in negotiation, right? So don't snip, just listen. By all means, convey your thoughts on the process, but derailing the negotiation with constant interjections is not going to be helpful. Sometimes you may wish to reflect back as to what you think the other party's position is, or in fact their interest. And this can be good practice to ensure that you've understood the conversation. And it may also help the other party to realise that their position is a little bit weak when they hear it reflected back to them. Ask how the problem's going to be solved, right? So open-ended questions, and that ask your opponent to actually give you the solution. Give them back some control in the conversation and allow you to workshop the practical realities of the solution. So, for example, can you please explain how you've arrived at that conclusion? Or how should we resolve this? Can be quite powerful, open-ended conversations that aren't laden with emotions, but are simply saying to the other party, well, look, what are we going to do? How are we going to solve this problem? And that can actually be quite powerful. This point gets back to my example of my teenage daughter who's terrible at taking out the bins. Seek a reasonable outcome. Figure out what you think it is that you need to achieve from the conversation. Think about what is actually reasonable in practice. So, for example, if you've asked a clinical opinion from another doctor, another nurse, an admitting team, you know, they may not agree with you, but you might feel that a reasonable outcome is they come down, take their own history, make their own examination, and write a comment in the medical records. And that may be all that is reasonable in the context, and that they may not be prepared to simply agree with you over the telephone. Compromising on the minor issues, I think, is okay. I've long since stopped arguing about ordering CRPs or full blood counts or additional chest x-rays, because who really cares? I'm a little bit more focused on the final outcome. So, sure, compromise on that. Don't obviously submit patients to dangerous and expensive radiological tests that are simply just mechanisms of the other party sort of dragging their heels. But occasionally a little bit of compromise, I think, is reasonable. And again, you just don't need to decimate your opponent. The relationships can be important, and no one will ever entirely capitulate. You just need safe clinical outcomes. Beware of the insincere yes. So this is my daughter that says she will take the bin out in 5 minutes. That's not a true yes. It's pretty insincere, and I know that, right? Sometimes we get strung along. That can make our blood boil when that happens. So think about how you're going to manage that situation. So sometimes a time deadline is reasonable, but sometimes it's not, right? There's no point setting a certain time whereby the patient will need to be admitted if you don't then have the authority to work around the other party. All right, so do be aware of the insincere yes, but then start to plan what happens if the agreement that you think you've got has not been carried out. Be firm. I think language is quite powerful. So cardiogenic shock might be a much better descriptor of the patient with chest pain who's hypertensive than some bloke in resus 2 with a soft blood pressure, right? So stating the facts as you see it. Again, if you're ringing up a colleague, this patient has an acute kidney injury, seems to evoke a bit more of a response than the creatinines, 120, 130. You can be both firm and polite at the same time. Consider your tone of voice. And look, make some concessions where that is reasonable, but at the end of the day, if you need to hold the line, but do it politely. And final means final. If you're saying to the other party, look, this is what I'm going to do, if we can't negotiate, then just do it. And that reflects integrity. And again, play the man, not the ball. Be soft on the people, but hard on the problem. And then the last rule, and then you all get a lunch break. Preserve the relationship, right? The world's smaller than you think. You will run into people that you're sitting in this room with now on the next couple of EMS conferences, right? Like, it is a small world that we're part of. And my example of my son being admitted at the other hospital was completely humbling. And every time I was told, yes, Dr. Banfield, I know who you are, I thought, gee, I hope I was nice to that person. In fact, I assisted a colleague whom I was his registrar in my medical legal job. And I had pointed out that, in fact, I was his registrar some years ago. And he'd said that. He goes, well, I hope I was nice to you. And I go, yes, you were completely fine. I actually enjoyed the term, thank you. And then we assisted him in his medico-legal matter. So it is a small world. But do pick your battles. To summarise my rules, they're on the slide there for you. A couple of concluding remarks. You can read it on the slide. But I guess disagreement is ubiquitous in healthcare. Try and minimise the emotion involved in negotiating outcomes, and consider the rules. Now, I'm probably done. Some of the questions have been really hard, so I'm very happy if Quinton just dismisses you and there is no time for questions. But I'll be hanging around for lunch. I've worn my Canberra Raiders shirt, so I'm distinguishable by the fact that I'm a Canberra Raiders fan. So happy to talk further on negotiation or the NRL. Don't really mind. Thank you.
Thank you, David. Thank you very much for that excellent presentation and for closing the conference off with us, because this is it, guys. No more formalities from here. So that's the good news. Tonight, there's no speeches, there's no more make sure you submit this or scan this QR code. There's going to be a saxophonist and a DJ. That's exciting. And that will be at 6 o'clock tonight on the rooftop bar. So if you haven't been up there yet, just the elevators from this building will get you up to the 7th floor. We'll hopefully have lots of signs pointing the way. If it is a little bit tricky to find, just follow the signs to the swimming pool, because you do have to just go up one more staircase. So that's from 6 o'clock, we'll be up there. Please come along. If you only can stay for one drink, that's fine. If you want to stay for longer, that's also very fine. Big thanks to all you guys. We've almost reached our goal of donating $10,000 to Heart Kits. So we donate a bit of profits each conference. So thank you guys. And also on the matter of thanks, big thanks to all our presenters this week. You guys have all been awesome. And lastly, and most importantly, this has been such a fun week for us. We've really enjoyed it. I think from day one, you guys have just really brought this really cool just sort of vibe with you. You're happy to you're open to discussions. You're all networking, you're talking, you're having fun, and that's really sort of resonated throughout the whole week and set the theme and the tone for such an awesome time. So big congratulations and thanks to all you guys. So we'll be out there tonight with we've got some matching shirts that we're pretty excited about. So hopefully we'll see you all there. Enjoy the drink and safe travels home. Thanks, guys.